Welcome, everyone, to our webinar today. I'm so pleased that you are joining us mid-August on this summer day. I hope everyone's having a great summer. My name is Jen Braun, and I'm the Director of Workforce and Organizational Development here at the AHA. So I'd like to welcome you to our webinar today on building age-friendly systems, a team-based approach to what matters and beyond. As Director of Workforce and Organizational Development, this is the perfect marriage between the two projects that I run. One of which is the AHA Team Training Program, which for those that aren't familiar, it is a program to encourage team-based care and to optimize team performance to improve patient safety. And the other project I work on is the AHA Next Generation Leaders Fellowship, which is a year-long program aimed at equipping emerging leaders with the skills that they're going to need to lead their hospitals and health systems. And so each fellow is paired with an executive level mentor throughout the program year who helps guide them through the development and execution of a capstone project. So I'm very pleased today to have our speaker, Adam, who was just a recent graduate of the 24-25 cohort, to present on the work he's done on building age-friendly systems and how teams are so integral to creating that. So we're going to get to Adam in just a second, but before we begin, just a few rules of engagement. So you can listen through your computer speakers or you can dial in via the phone. If you have any questions on that, please feel free to chat in, but everyone's in a listen only mode. So just please note that. If you have questions throughout the webinar, again, chat them in. If they're more logistical or technical in nature, we'll answer them in real time. But if they're for our speaker, we'll save them for the end and do a Q&A. And again, this session is being recorded, so the chat will not be included. So if you wish to share this recording with a colleague after, or you want to revisit it, we'll be emailing everyone who registered, notifying them when that recording is posted. And again, to just orient everyone to the chat, please note that you can chat to everyone. And so make sure that that's reflected in the photo there in the bottom right corner of your screen. And so as we continue on here, today's presenters, I'm very pleased to introduce my colleague Autumn Branch, who is a program manager and works very closely with age-friendly hospital systems and the work that the AHA does. And I already kind of teed up Adam. Like I said, Adam graduated about a month ago from the 24-25 cohort of the AHA Next Generation Leaders Fellowship. And he comes from Novant Health. So I'm very pleased to introduce our speakers today, and I'm going to toss this over to Autumn.
Thanks so much, Jen. Thank you for having us, and thanks to all of you who are joining us today. On this slide, you'll see our agenda for today. We'll start off with some intros, so please go ahead and type your name and organization into the chat so that we can say hello to you. Then we'll discuss the age-friendly movement and provide an overview of how you can get involved through the AHA Action Community, which is actually enrolling now, so you're in luck. From there, I'll turn it over to our wonderful speaker for the day, Adam Kuntz, who will discuss Novant Health's approach to age-friendly care, and then we'll have some time for Q&A. And finally, I will close us out with some next steps and instructions on joining AHA's Fall Action Community. Thanks everyone for chatting in your name and organization. Hello, hello, good morning, good afternoon, and thank you again for joining us. So before we jump into the meat of today's presentation, let's get a sense of what age-friendly means to you. You can go ahead and use the chat box. I know I still see a lot of names coming in. There's hundreds of you here today, but please go ahead and use the chat box to share what age-friendly means to you. I know we've got folks joining us who have been in action communities before, and then some folks who are just here to listen and learn. So go ahead and type that in. I saw patient-centered care, accessibility, what matters most to the patient at the top of 5M's care, equity in care, being able to care for the aging community, best practices. Yes, yes, meeting every patient where they are based on what they need. These are great responses. treating the patient as a whole and unique individual targeted processes for the aging generation. Yes, yes. Great answers. Thank you so much, everyone, for typing those in the chat. Feel free to continue to chat in throughout today's presentation. All right. As we think about the national and global impact that the age-friendly movement has had thus far, we want to express our gratitude to the John A. Hartford Foundation, a private philanthropy based in New York that has been dedicated to improving the care of older adults. Since 1982, the foundation has invested more than $737 million in aging and health. It has developed a field of aging experts and has sourced the testing of innovative evidence based models. They are the reason that we are all here today. So, as we know, hospitals, health systems, and healthcare facilities need to be age friendly and support the needs of older adults now more than ever. The number of adults age 65 and older is projected to double. From 40 million to more than 98 million by the year 2060. And as you can see on this slide, their growing demography complexities that they face in their health as they age and the disproportionate impact they have to diseases such as COVID-19 makes age friendly practices more important now more than ever. This initiative can help you consistently, reliably, and efficiently provide the very best care to every older adult, every day, in every setting, and bring value to the patient and to your organization. So, becoming an age friendly health system entails working towards reliably providing a set of four evidence based elements of high quality care, known as the four M's, to all older adults in your system. Many of you have been introduced to the four M's before, but it's important to highlight that the four M's are the core of being an age friendly health system. What matters, medication, mentation, and mobility, which you can see listed here on the screen. Those are the four M's that make care for older adults that can be complex, much more manageable. The four M's, formed from extensive research and 17 different care models, have shown to improve outcomes, reduce the risk of harm, lead to better care experience, and save money when performed together, ultimately achieving the cardinal aims of the modern healthcare system. Some core principles of an age friendly health system are that the four M's are a set to be integrated together into care for every adult age 65 and older during every stay and over the course of a year in a primary care setting. The four M's are a framework to organize the efficient delivery of effective care with older adults. Age friendly health systems and the four M's framework are not intended to be a model or program that is just layered on top of the care you provide today. Age friendly health systems are designed to close the gap between the evidence based care that we know works and the reliable practice of that care with every older adult in every interaction. It is highly likely, which is the good news, that some of the four M's are in place somewhere with some older adults most of the time in your care setting. The four M's help you build on and better organize what you are already doing. The four M's in many ways are balancing measures. For example, we wouldn't want to screen for delirium without having a corresponding medication to ensure that there wasn't an increase in use of antipsychotics to manage those delirium symptoms. So, when we started this work in 2017, we had three goals, which are listed here on the screen. To build a social movement so that all care for older adults is age friendly care. They are guided by an essential set of evidence based 4Ms, or I'm sorry, of evidence based practices known as the 4Ms, cause no harm and are consistent with what matters to the older adult and their family. What matters, as you'll see either throughout this presentation or if you were to join the action community, throughout the action community, what matters is often the core and the root, the foundation of that 4Ms care. Our other goals were to reach older adults in 1,000 hospitals and practices and have them be designated as age friendly health systems by the end of 2020. And then that other goal was that by the end of June 2023, we would have 2,500 hospitals and practices and 100 post acute communities who were recognized as age friendly. The importance and impact of this movement is underscored by the results we've accomplished. We've not only met but exceeded our goals with more than 5,000 hospitals, practices, retail clinics, long term care facilities, and now home health organizations who put the four M's into practice and have earned the age friendly designation. And more than 2,000 of those have continued on to become committed to care excellence designated sites of care. Now, let's talk about the AHA action community and how you can get involved. So, again, in 2017, when we started this work, five U.S. health system pioneers partnered with the Age Friendly Health Systems Initiative to test the forum's framework, refine, and scale up the Age Friendly Health Systems framework in hospital and ambulatory care settings. We have some short case studies on them, which we'll highlight in some later slides, but you can also read about them on our website, aha.org/age friendly. You can learn how they have successfully implemented the four M's at their organizations, which has led to reductions in patient length of stay and readmissions, improvement in patient family engagement and patient satisfaction, and a positive return on investment and improvement in patient safety. The Action Community itself is a 7-month virtual learning community that is working towards reliably implementing the four M's in your local setting. The Action Community provides an opportunity to implement and test these resources in your care setting. This will be the seventh Action Community that the AHA will be hosting. A few things to note. Multiple sites of care within a hospital or health system can enroll in the action community at the same time. There is no cost to participate thanks to the Johnny Hartford Foundation. Participating in the action community is completely free. The cost of participation includes only the time that your team is going to allocate to participating in this 7-month action community. Um, like webinars and data collection and tests of change. The action community testing and learning period is designed to occur as part of each person's existing activities and is therefore a repurposing of time rather than incremental additional time. For example, a hospital or practice will generate a review of quality reports as part of their standard work. But as part of the action community, certain quality indicators might be segmented by age. The types of activities that are available to a site who enrolls in the action community is shown on this slide. It includes 2 monthly calls to review content focused on the four M's. So, in those calls, you have an opportunity to highlight your progress and learnings with others. We also have expert speakers like we do today who share their stories as well. During the action community, you'll also be testing changes in your interventions. We'll be having a virtual convening, which is a 2-day event that will take place in January of 2026. During the action community, you should also be prepared to share data with our partners at the Institute for Healthcare Improvement. And this data and this forum's care plan is going to be what you submit in order to get that designation as an age-friendly health system, which I briefly mentioned before. One of those webinars that we have on a monthly basis is our topical coaching calls, and this is where your team can meet and discuss whatever topics are mostly important to you at that time. And then on this slide, you'll see an overview of the Action Community schedule and activities. So as I mentioned, we are currently recruiting for our Fall Action Community. We'll have our kickoff calls in September, and then we'll officially kick off with our educational webinars in October. And then in blue on here, you'll see highlighted the virtual convening, the 2-day event that will take place in 2026. Again, we'll have those 2 kickoff calls that take place in September, basically overviewing what you can expect as part of the action community and ground setting us before we get into the actual content. So we walked through a very high level of the different types of webinars and events that you and your team will engage in. So now let's discuss examples of the work your team will do in between those webinars. A lot of this will include learning and testing the four M's in your site of care. We do suggest using a PDSA cycle, but you can use any other mechanism that works best for you to test and learn your way into going from developing your definition of the four M's and how you are actually going to put those into practice. Your work in the action community, as I mentioned before, will be recognized as you go. Everything you do will contribute to getting nationally recognized as an age friendly health system. There are two levels of recognition that you will work towards as part of the action community. Level one recognizes you as an age friendly health systems participant. You will receive this recognition upon submitting your 4M's care description to the Institute for Healthcare Improvement, which is basically your action plan. How are you going to implement each of the 4M's, what matters, medication, mentation, and mobility in your site of care? For example, you will submit which tool you will use to screen for dementia and how frequently. Your submission will then be reviewed and approved by IHI, and once approved, you will implement your action plan and work towards level two. Level two recognition is called Committed to Care Excellence, and that form of recognition is awarded to those who have submitted at least 3 months count of the older adults that they have touched with their 4M's care. So you've created your care plan and then got it approved by IHI, and then for level two, you're going to submit the number 3 months count for the number of older adults who've been impacted by that new care plan. And again, we go more in depth about this in the action community. We offer one on one coaching if your team needs support. Um, but yes. So, because of the great work being done by care settings across the country and across the globe, more than 3 million older adults have been reached by 4M's care. After participating in an action community, teams have reported decreases in length of stay, decreases in readmission rates, decreases in fall rates, and increases in ROI. We've also received amazing feedback on the action community experience and impact realized after implementing the 4M's. So, if you're excited about the great outcomes that other teams have seen, and if you're ready to get your team on board, we invite you to join us for the Fall Action Community, which is enrolling now. You can visit our website at aha.org/agefriendly to learn more, and don't hesitate to reach out to us via email with any questions. There's also a QR code, which should work, on the screen that you can scan that'll lead you directly to our commitment form. And then in the chat, my colleague Jason is also dropping in our invitation to join us for the fall 2025 action community, and then also the link to that will lead you directly to the commitment form. I do see a question. Can we sign up for a second year? Absolutely. We have teams who join us year after year just so they can stay up to date with the latest and still have that community where they can connect with their peers. And if you can't make this at September deadline, you're still welcome to join. We keep enrollment open through October at the earliest, and sometimes, depending on various factors, we might keep it open till November. But if you join in November, we'll just have you do a separate onboarding call so we can catch you up on anything that you may have missed. In the event that neither of those time frames work for you, IHI, the Institute for Healthcare Improvement, also hosts a spring action community. So you will be welcome to join that as well. Hi, Diane. Welcome. Sorry, just saw your name, familiar name in the chat. All right. So with that, now I will turn it over to the Senior Director of Advanced Care Planning, Clinical Ethics, and Spiritual Care at Novant Health, Adam Kuntz. And feel free to continue typing in questions in the chat. We do have a Q&A portion set aside. So we'll make sure that we get to those questions.
Thank you, Autumn and Jen. Hopefully you can see my screen.
Yes, perfectly.
Very good. Well, good morning. I think for most of you trying to quickly scan the chat, I think most of you it's still morning. It's a tremendous honor to be here to share a little bit with you today about the work that we've done leaning into the age-friendly space. I want to start by first expressing gratitude to the invitation to be a part of this and to sing the praises of both the AHA Next Gen Leaders Fellowship Program and the Action Community. I've certainly benefited, and our system has benefited tremendously by participation in both of those programs, including the fellowship engagement and the action community, the coaching call. Everything helped kind of keep moving our work forward and challenge me to think about some things in different ways. And so encourage any of you that's not connected already to explore those. So as I get started with my part of this presentation, I wanted to start a little bit with my why, partly just to let you know a little bit about me, who I am as a person, and who's talking to you today. But also because I think this is a truly critical part of change management and leadership, particularly in healthcare and particularly today. And so to share a little bit with you about why I lean into this space and why I'm in the work that I'm in. As you look at this slide, I'll start on kind of the left side of the screen. You'll actually also see the same star hanging on the wall behind me. This is a used for a brief period of time, World War II U.S. Navy insignia on various vessels. This one came, this star is from the airplane, an open cockpit bi-wing airplane that my grandfather restored and flew for most of my childhood. And from the time I was big enough to put 3 extra booster cushions under me and strap myself into the seatbelts, I joined him in that plane and flew with him a tremendous amount of time. And it is one of my fondest memories for sure. Fast forward a little bit, when I was 16, my grandfather and my uncle died in a private plane crash. The star that you see on the wall behind me and in this image was actually cut directly from the wing of the wreckage. I was the last person up in the plane with my grandfather the previous Sunday before, was the one who answered the phone when my family called to inform my mother about this. And at the age of 16, certainly had an impactful resonation through the next couple of years of my life as I leaned in, watched how my family responded to this, and felt like there were opportunities for us to approach end of life and death and dying better in our society. And so to spend a lot of time studying and leaning into that space. Fast forward, another 16 years, the 2 images on the right side of the screen are really what I'll refer to as kind of a tale of 2 grandmothers. The middle image that you see, I could also probably title an assessment of just how country are you, because I could determine who the people are that recognize this. These are doodlebug holes at the farm at my father's home farm. I used to go out as a child and stir the dirt in these and try to coax the doodlebug out of this hole as a child. But that grandmother ultimately lived past 90 and experienced advancing dementia over the last several years of her life. And staying at home on her farm was one of her real key priorities, especially as long as she could continue to get her hair done every other week and attend church on Sundays. And so my father, his sister, her family worked hard to continue to support that life of what was important to her as long as they could through that process. The other image is a wire hair fox terrier. That was my other grandmother's dog. She had a couple, but one towards the end of her life. And that grandmother ultimately succumbed to fibrous lung disease. And so that was a progressive decline over the last several years of her life. When she remained, in contrast to my other grandmother, sharp as a tack, mentally, all the way up until her very last day, including the decisions of when to stop artificial, feeding, when to take the nasal cannula and oxygen off, as she realized what mattered most to her was being home with her dog, visiting with family. And over time, she certainly became aware that more and more of her time was being spent in the hospital than at home, connected to those people. And so when I think about these scenarios that impacted my life early on, what I recognized is for those of us in healthcare, we can't always impact those situations like my grandfather and my uncle, where there's sudden loss of life and the healthcare journey, is kind of abbreviated. And that emphasizes to me the real importance of the scenarios like my 2 grandmothers of when we are connected to these people for weeks, months, years of their healthcare journey, how important it is for us to try to lean in and provide what matters most to them. You'll see at the bottom of this slide, my tagline for the last several years has been that my purpose in this world is restoring and sustaining the humanity in healthcare, both for those who are receiving the care as well as for those who are providing it and our teams. My initial connection to the age-friendly work really kind of started before I knew there was age-friendly work. For the last 10 years at Novant Health, I've been responsible for being one of the business leaders for what we call Choices and Champions. That's our transformation around leading up to end of life. It's really about knowing and honoring patients' wishes We emphasize conversations over legal documents. We do help patients obviously complete legal documents, but we focus more on the conversations with the family and with the care team. It results in us taking an approach of looking at advanced care planning from what do you not want when you're dying, which historically is the approach. I don't want a breathing machine. I don't want to go to a facility. I don't want chest compressions, those kinds of things, to what do you want while you're living. And we really leaned into this work. And as the title of this webinar alluded, we talk about the team approach to what matters. And we identified several pathways for multiple members of the interdisciplinary care team to contribute to advanced care planning notes for patients and document what matters most to them. We track this as a long-term goal, and our system work in this space ultimately allowed us to receive the Circle of Life Award from the AHA in 2020, a tremendous accomplishment, and we continue to build on that. And coming out of that work, I learned about the age-friendly health system work, and it felt like a really natural next progression. Took a little while with the COVID pandemic getting in the way for us to kind of get to intentionally leaning into this space, but we have, and I'm excited to talk about the kind of front half of this journey or the start of this journey as we continue to move forward and learn from other people and improve on our processes. So Autumn touched on some of these first two slides, but I included them and left them in here because I think it's important to think about how we teed up age-friendly health system work to our teams as we leaned in and engaged with them. So we talked about the history, where it comes from. I think a lot of times in healthcare these days, especially for those closest to where the value is delivered, it can be easy to feel like we have one of two scenarios. Either we have a whole lot of challenges being presented with not a lot of solutions. And then on the other side, the flip side, sometimes it can feel like we have a proposal of a whole lot of solutions that may not actually have a problem or challenge identified with them. And so I think it's really important when we introduce a new process or change that we help people understand where it comes from, the background behind it, who it's been vetted by, some of the impact that it's had from other systems. This is an area where I really appreciated the Action community and the age-friendly website to look into other success stories and help people understand where there's been success for other institutes in this space. Autumn talked about the 4Ms. We certainly offered education to our teams around the 4Ms and utilize this framework to educate to them, speak to each of the 4Ms and the importance of it, and start to consider what work were we already doing, what did it look like to roll this out, and where could we potentially capitalize on existing work, key wins that was already happening. And so I'll speak a little more about that here in a minute. In essence, at its core, the age-friendly framework asks you to assess, these things, assess the 4Ms, what matters, medication, mentation, mobility, and then ultimately to act on it, to do something with that information, such as align the care plan with what matters, deprescribe high-risk medications, assess oral hydration, orientation to the unit or to time, place, their environment, the unit, and prevent sleep disruptions in pharmacology. I included this slide because it's, it's what it is at a high level, but it also for me is kind of the emphasis on a team approach for this work, because very rarely in most healthcare settings I'm familiar with today, is it likely that the same person is going to be consistently doing the assessment of these things and also consistently doing the act on these things, whether that's because of shift changes, competing priorities and demands in their workflow. And so by essence, this needs to be a team approach. And that's what we found with our Choices and Champions work. And that's where we recognized the age-friendly work was to be able to move forward, that this would need to be a team kind of collaborative approach. Autumn shared some other data on kind of the impact on organizations, but I wanted to share a little bit of what we've talked about and looked at from kind of a national level when we think about the why. Most of us are aware of the silver tsunami or whatever you want to call it if you work in healthcare that we're in. CMS would indicate that in 2020, the age 65 group was the smallest group at about 17%, but accounted for about 37% of all spending in 2020. So at times where we're looking at how do we manage cost of healthcare, certainly a key group to be able to focus on, lean into, and identify how to support and maybe reduce cost without impacting the quality of care. PRB.org would indicate the number of Americans age 65 or older is projected to grow from 58 million to 82 million uh, between in 2022. And projected population rise from 17% to 23%. So you multiply that previous stat I talked to you, by an additional 6%, it grows pretty significantly. And obviously, patients 65 or older, I think, as many of you alluded to in the chat, when Autumn asked what age-friendly care meant to you, recognize that as we age, life gets more complicated, right? We recover from things slower. We're more likely to experience comorbid conditions along the way and have increased impact or effect on us from drivers of delirium, polypharmacy, and reduced mobility. I wanted to include this slide about our cause, partly because, one, I'm really proud of the work that we do at Novant Health. We have a tremendous team at Novant Health all across our system of 19 hospitals and over 800 medical clinics that works hard to live out our cause, to create a healthier future and bring remarkable experiences to life. And when we started talking about age-friendly work, I think it's really important for any change initiative to be able to connect back to system priorities and system mission. And so when I think about this, when I think about bringing a remarkable experience to life in the healthcare setting, a lot of times people talk about exceeding expectations, delivering, above and beyond. But I also think when we talk about delivering a remarkable experience in healthcare, getting a person back to what matters most to them in their lives as fast as possible is one of the most important things. And so that aligns directly with this age-friendly work. It also aligns with the other elements of our calls here: discover, empower, thrive together. Obviously, we're trying to discover new ways to support these patients and move them through the process. We're working to discover what matters most to them and then empower them and our care teams to move them forward so they can thrive. And I already talked about togetherness, the importance of this being a team-based approach across the system. I'm going to talk a little bit about kind of when you go all the way back to grade school, the who, what, when, where, why, and a little bit of the how as we go through this conversation. And so, in terms of the where, to initially lean into this work, we chose Novant Health Thomasville Medical Center as the location to start some of our pilot work. And that was for a couple of factors. One being the hospital president there at the time had talked to me about the age-friendly work. And over the couple years of COVID, while we were kind of waiting to be able to move forward with this, he stayed really engaged and really interested and excited about this. And so that was one factor, obviously having leadership buy-in and leadership support at the facility. The other reason was using a data-based approach. And so we looked at demographics across our system and the communities that we serve. And Thomasville Medical Center sits in Davidson County, where the 65 plus population was the fastest growing population between 2010 and 2022. You see here, if you look at that second bubble line down, you see the just tremendous size of that line in terms of the growth. But I'll also point out that the biggest group of the Davidson County population is that top bubble line, which is the 50 to 64. And this was 2022 data. So many of those people are already in the 65 plus category now, and are certainly ones coming into it over the next 10 to 12 years. And so that data drove us to choose Thomasville Medical Center as our kind of focus or starting point. From there, we wanted to look at the who's involved, who's connected to this work, who's helping us move forward. I will acknowledge that the guide to implementing the age-friendly health system work from AHA IHI does a tremendous job of offering a template, a tool for a lot of this process. And if you follow it along, it really gives you a blueprint for implementing so much of this, including a recommended work group makeup. This is a revision of that list with some addition of ours of looking at the 4Ms and just asking ourselves who needs to be at the table for this work. And so we assembled an internal work group at Thomasville Medical Center. That's what you see on the left side of the screen in each of these roles, kind of going across all kinds of the services and the interdisciplinary team that have varying levels of touch point kind of directly related to each of the 4Ms and work that was being done. We're now in the process or have shifted, I should say, to a system-wide work group as well, as we're looking to move this from Thomasville Medical Center to the entire system. And so we added some additional teams from system resources, system support perspectives that I list here on the right side of the screen, largely around data and analytics, clinical practice, and education. Our Dimensions and Epic team to support us with documentation and reporting around this work, and our health equity team. and community health team. I specifically leaned into this work and developed a capstone, as Jen mentioned, as part of the AHA Next Gen Leaders Fellowship Program that I started just over a year ago. And as we started to lean into the space and lay out the blueprint, I received the gift of CMS. If you're not familiar, CMS chose to implement age-friendly measures into attestation domains of their inpatient quality reporting for fiscal year 2025, which means the work done or excuse me, fiscal year 2027, which means the work done in 2025. And so that compounded things a little bit. And so and then as I was leading this work and talking to people occasionally across the system, someone would say, "Oh, Adam, we're doing that geriatric work over at such and such," and they'd name one of our facilities. And I felt pretty strongly that we weren't doing age-friendly health system work. And so as I leaned into that space, what I discovered was we now had kind of three main frameworks looking at age-friendly or 65 plus care across our system. And these are certainly not the only ones. There are others out there nationally that you may be familiar with or utilizing in your system, but we needed to be able to look at and align these three things. The geriatric ED certification from the American College of Emergency Physicians. Three of our facilities are designated as bronze facilities in that space historically. And so needed to consider that and how it aligned with the age-friendly work. And then ultimately, how do we align this with CMS, IQR domains that we need to report on going through 2025. And for those not familiar, these are attestation domains. So every inpatient facility connected to CMS, will need to attest to these domains. What that means is you just have to say yes or no to, are you doing something here? You don't have to provide data yet. The expectation is that that's coming in the years ahead. And so we're working to ensure that we can report on these. Part of the conversation was, are there any of these that we're comfortable saying no with or could make a case to say no to? Or do we want to be able to say, yes, we're doing all of this and kind of move it forward? And so that built very naturally on the age-friendly health system framework. The other piece that I'll say about this is as I've looked at these three kind of frameworks and talked to others at different conferences nationally over the past year and other fellows participating in the fellowship, the AHA age-friendly health system process and action community and the guide that they offer is the clearest and easiest to follow in terms of giving you a framework and helping you walk through the process of implementing this. And if you do that, as you can see on this slide, you will likely meet most all of the CMS expectations or domains and be able to check yes, with a little bit of a need in that social vulnerability space and identifying leadership within your system to continue to lead the work moving forward. So as we looked at the CMS inpatient quality reporting domains, we developed this slide along with our data analytics team. So it was really important for me. They're the ones who helped drive a lot of our CMS reporting measures. And so I leaned in with them. They helped connect on this, and we highlighted what are the actual deliverables, what are the things we want to connect with and say yes to. Do we have the right people on our work group for each of these things moving forward, and confirmed that we had the right people in the room? Now we knew our correct targets. What is it that we're kind of looking to address? And now let's go see what we do with this. And so this on the left side screen is a screenshot from the care designation form that you submit when you seek to become a participant in the age-friendly health system process. And this is the one for What Matters. I shared it on the screen today because we used this really as the template in our work group meetings for our first several meetings. That we conducted a brainstorm of current activities because the idea was hopefully we're already doing this in a lot of our settings. And so we wanted to make sure that we accounted for quick wins and celebrated successes that were already done, didn't reinvent the wheel and weren't redundant. We filled the blue box that you see here and then some up on most of the 4Ms with different things going on. So this process helped us in some ways identify where we may have had redundancies or where we were maybe using, for example, a competing assessment tool for mentation on different units, and determine, is there opportunity for us to streamline, narrow down to one assessment and look at that. The form also then challenges you to look at frequency, how you're documenting it. That was one of the things that was really noteworthy for us in the initial look at this, was that there was a lot of good work happening, but it wasn't necessarily discreetly documented, as was mentioned earlier, in places in the medical record so that we could easily pull and harvest data kind of connected to it or around it. And then we conducted a gap analysis and worked to pare that down. We also worked, I'm not going to spend a lot of time on the slide, it's a really busy slide, but I just wanted to mention as we talk about the data process, the data analytics team then went through with us and identified every data point that we already collect in our system in our data repositories, whether it's currently actively reported in a dashboard or in the back of the house, just kind of collected. And we identified those data points and aligned them with the different 4Ms and then the other CMS expectations, so we knew what data points we had. Then from a team-based approach, I label it here as kind of a hub and spoke teams approach because that's how it kind of looks when you bubble map it out. Though I certainly would have to acknowledge that all of these other teams existed before the Age-Friendly Health System work group existed. So it's not like the Age-Friendly Health System work group is driving these other teams entirely, but is coordinating across teams, identifying best practices from those teams, and then collecting it together in how we're responding and implementing the 4Ms across our system. Whether that's Choices and Champions team. I'll certainly mention the IDT rounds. We call them patient progression rounds. And so that's one of the key areas where we've at Thomasville Medical Center educated around the 4Ms and talked to it. That has many of the key players on that list earlier who are closest to where the value is delivered for these patients, assessing the 4Ms and determining what may be contributing to any delays in progression and getting that patient back to what matters most to them. And so just very briefly in my time, I'm not going to spend a whole lot of time talking about the what we did because as I kind of noted earlier, we had a lot of best practices already existing in our system. I imagine many of you already do too. I also think it's really important that you fit your response to the 4Ms to what works for your system and the teams that you have and the resources that you have. I had the opportunity to connect with fellows who were working at 25-bed critical access hospitals through the action community and through the fellowship. And obviously there were very different approaches to how I'm doing things at some of our hospitals and how they're implementing the 4Ms. And so there is a need to customize it. And I think the care designation form and working through the process really helps you identify that. But just in brief, in terms of the what matters, we have an admission question. I'll tell you, we're in the process of in a PDSA cycle on this. This was a question that already existed in our system, and we've identified from our work that this is a question that's too clunky and too confusing, and so we need to improve it. So we're working to retool it. We have a question available through a MyChart questionnaire. We call it the Patient Entered Wishes questionnaire that asks a number of questions around what matters to the patient and what's their preferences. The first question is, what's most important in your life? And we talk about that and then share that with the care team. That's currently optional, so not across all of our patients and not a standard of care. And then one question that during our Choices and Champions work we implemented with our pre-anesthesia call, pre-anesthesia visit teams, where they were had a little challenge at first of Adam, how do we talk to patients right before a surgical procedure about advanced care planning and potential care wishes and end of life. And so we ultimately landed on this question of what do you most look forward to getting back to after your procedure? And that wound up resonating really well and working really well in those pre-anesthesia visits. For medication, all of our pharmacists are familiar with the Beers criteria and utilize that across our standardized MedRec process every 24 hours and upon significant change and when a new medication is ordered. We do have a BPA that fires when a potentially inappropriate medication is prescribed. I also recently at a conference learned about a geriatric prescriber context that actually can set the defaults on certain medications to an age-friendly recommended amount that we're exploring and looking into. So continuing to learn and innovate with what we do by learning from others around us. Mobility was one of the areas where we had a couple different tools being used in lots of areas. And so we're working to standardize around use of the BMAT, in particular, starting with the ICU and expanding in our med surg units. PT and OT use some additional assessments, obviously specific to their roles with certain patients and on consult. And as you saw on that bubble map of the teams, Thomasville Medical Center has a really active multidisciplinary mobility and falls committee that's repeatedly doing PDSA actions on our mobility and how we can best utilize that, whether it's mobility techs, nursing practices, and other things around getting them up for meals and things like that. And Mentation, again, some standardization opportunities here. And so we've identified the CAM and the CAM ICU as a standard tool that we'll use kind of across settings, and have started to do that. And then looking at nursing practice and interdisciplinary rounds on making sure we're orienting the patient, assessing for delirium, making sure patients have their personal adaptive equipment that moves along and that follows them throughout the hospital system. And so that's kind of the really quick sprint through this. And as I kind of finish up my time with you, I want to come back to a patient scenario. I talk a lot about the quantitative data, and you can see that out there. And there's certainly some pretty powerful data through the resources from AHA. And qualitative data is really impactful and important too. And so I want to tell you about a story for the sake of today we'll call Mrs. Jones. Mrs. Jones was a patient that came in, visited us, was planned for an elective lower body surgical procedure, went through the pre-anesthesia process, was asked about what matters most to you, as I talked about a minute ago, progressed through the process, through the procedure, and in with us, and then began to have some challenges, have some struggles. And long story short, Mrs. Jones was a patient that back when I was in the hospital would often hear as described as a failure to thrive patient, just not up, moving, not progressing in the recovery from the procedure, and moving on. And so as I think about this related to the 4Ms, this is a patient where any of the 4Ms could have identified, been assessed, and likely helped us move things forward. In terms of mobility, obviously there was mobility challenges before the procedure. So were we moving her enough going into the procedure to set her up for success after the procedure? But also we were clearly having challenges getting her up and moving after the procedure. So that was pretty clear. Medication, were we over sedating? Were we giving pain meds that were contributing to, grogginess and inability to get up and move in this space? And so the medication piece and mentation around that. In this case, though, the piece that I'll highlight and the part that I always come back to is ultimately what really made a difference for Mrs. Jones was the first of the 4Ms, the what matters. And so when the pre-anesthesia team asked Mrs. Jones, what do you most look forward to getting back to after this procedure? She said, oh, working in the garden. I just love that. That's what I love to do, and that's how I spend my time. And fortunately for Mrs. Jones, on paper, in a chart note, that doesn't necessarily seem that impactful sometimes. But in Mrs. Jones' case, fortunately for her, one of the physical therapists that was assigned to work for her had seen that documented in her chart in the advanced care planning note. And when they went into work with Mrs. Jones that day, they said, Mrs. Jones, I saw you like to work in your garden. Spring's coming. What are you going to plant? Well, I'm curious, how far from your door is your garden? And Mrs. Jones said, oh, not far, about, 20, 25 feet. And the PT said, okay, well, how about this? What if today we work on getting you back to your garden? And they marked the distance to Mrs. Jones' garden down the hallway. And so we just moved from our goals of treatment to have the patient ambulate 30 feet with the assistance of a rolling walker to the patient's goal of care, getting her back to her garden. And so when we can start with what matters most to a patient and align the care plan with that, we can overcome a lot of challenges and help our patients be really successful. So I appreciate the opportunity to share all of this with you. I think now we'll move into some discussion, some Q&A with us. And so I'm going to stop my screen share and we'll shift to questions.
Thanks, Adam, for that great presentation. Appreciate all of the quantitative and qualitative datas and stories. A couple questions that have come in through the chat, and I'll ask my team members here to chime in or let me know if there are other questions to bump up on the list. But have you worked with community health workers or community reps that were utilized in your care team or work groups through any of this work?
We have not currently in our process. I've actually got a sticky note on my, on my computer screen, and one of the notes on it is to connect with our leader of our community health workers and look in
Mhm.
that space. I know one of the things across the areas that I lead, spiritual care, advanced care planning, others that we're looking at is we continue to expand our hospital at home program and recognize those are hospital level patients that need the same kind of hospital level support that we offer to our others. And so we're looking at how we can expand some of all of what we do out into the communities more.
Excellent. There's a lot of questions and comments. So I'm trying to go through all these, but um, maybe I'll open this up to my age-friendly colleagues on the chat or on the call too. And Adam, please jump in. But has anyone seen the implementation of the 4Ms framework in the skilled nursing facility setting? So Autumn might turn that to you, or Adam, I don't know
Yes.
if you guys have
Yes,
any
I'm here.
connections. Yep.
I'm here. Yes. So we do have guides for long-term care facilities, nursing homes, and now we have home health care. Let me drop this link in the chat. I think that might be most helpful. But feel free to reach out to us offline so we can talk more about what exactly you need. I'm going to drop this link in the chat. Let me just change it to everyone.
Thanks. And I believe we've had a fellow in the Next Generation Leaders Fellowship program from a skilled nursing facility work on implementing the 4Ms at her facility too. But as you chat that in, Autumn, question back to you, Adam. How do you deal with or communicate with the patient if their goals surrounding what matters might not be realistic? How do you handle that difficult conversation sometimes?
Yeah, I appreciate the question. I saw that in the chat. And
Mhm.
interestingly, one of the main things that I do in our organization is I facilitate a session on difficult conversations.
Mhm.
And over the years, we've done an 8-hour workshop called Mastering Conversations That Matter. That's all about how to navigate difficult prognosis and diagnosis conversations and manage unrealistic or potentially unrealistic expectations. Often, what it comes down to is the care team's desire to not take away hope.
Mhm.
And so one of the key tools that we have educated team members on, in very brief to respond to the question, is the use of hope and worry.
Mhm.
And so to say, I hope we're able to accomplish X, whatever it is that they name. And the and is important. It can't be a but. And I worry this may be as good as you'll feel, or I worry that you may not be able to walk that far to get, to
Mhm.
graduation, whatever it may be. And if we can balance the hope and worry, the patient can still hear the care and concern for their
Mhm.
goals, and you
Yeah.
don't have to completely delete their desires or hopes, but can still lift it up and give accurate clinical information around where to go next.
Right. And so with this work, could you share a bit more about the education and perhaps training that you provided staff surrounding this work?
Yeah, we're looking at that's one of the things we're in PDSA on. We did kind of in person, close face to face. We're now assessing what would be moved to broader kind of webinar CBL, kind of training for our broader system. That's part of what the system work group is looking at. You'll go back to that team and work group slide that I included, and note we included our clinical practice and education specialists, and so we're looking at that now of how do we educate the bigger teams. Thomasville is small enough that we're kind of able to do it in a direct, from me to the team through handouts and through resources and conversation education approach.
Right. And so kind of along a similar vein, what barriers did you run into with frontline staff on connecting to the 4Ms or really getting that engagement and ownership over this really critical piece of care for older adults?
Yeah, I think in terms of barriers we encountered, I saw some comments in the chat. One of the barriers that was alluded to is we already do that. And so I talked about that. Part of our approach was literally to do that brainstorming and say, what are we already doing in this space and where can we highlight we already have the win? And the hope was that 80% of the work would already be identified. Um, the other challenge is uh, that the closer you get to where the value is delivered, the more those team members feel like every initiative the healthcare system rolls out sits on their shoulders. And so we go talk to physicians about this and they say, hey, that's great. This is really important.
Mhm.
If you can figure out a way to not make it sit with the provider, that'll be fantastic. And then you go educate with nursing team members and they say, this is fantastic. If you can figure out a way to not make it sit on nursing, that would be fantastic. And so to me, that just reinforced the need for the team approach. And then Jen, you use the word ownership. I think the other thing that's been really important for us in this work is ambiguous ownership creates no ownership.
Mm-hmm.
And so you can't just say this is a team project that the group's working on. You do have to
Mm-hmm.
look at each of the 4Ms in each process and kind of identify. But by dividing and conquering that, I think teams can be a little more amenable to the lift. The other piece is getting to the why, which is why I started with
Mm-hmm.
that at the front of the
I
presentation.
I
You can
love
help
that.
people understand their why, and it shouldn't
Mm-hmm.
be hard with this work because all of us have someone
Mm-hmm.
age 65 or older probably in our lives that we're
Right.
familiar with, or recognize that 65 is not that far away for some of us as we may think, and can certainly have a reason for why we would want this to be implemented and delivered
Yeah, I
effectively.
love that you put that at the top of your presentation because that really hooked me in. And so, did you have to, kind of along the same vein of stakeholder engagement and ownership, how did this come to be, or how did you secure executive engagement on this work? And do you have any suggestions for others who are looking to bring this to their organizations and may not have that in place at this time?
I think part of our success was on the success of Choices and Champions. We had done kind of similar work that was a precursor that led to it. But I think the other piece is really being able to connect it to the other things that are a priority for your healthcare system. And so I mentioned a little bit of that earlier. So I went to our Chief Quality and Safety Officer and presented it to him and talked to him about it. And he said, oh, this directly aligns with this, and named like 7 things that his team was
Mhm.
working on and looking at that aligned with it. I went to our chief experience officer as we were looking at a 3-year long-term goal on patient experience, and clearly there's a very direct connection. And so the ability to align it with the other high system priorities, I think, is what really helped with getting buy-in and support.
Yeah, and I think we find that throughout, any of the work we do, that if we're able to really connect it into our organization's strategic priorities, the mission, the vision, it's hard for sometimes those executive leaders to say no to that when there is such a clear connection. I'm trying to see if there's any other questions. Autumn, is there anything else I missed? I know we might have time for one more question.
Yeah, there's a few more questions in here, but if it's okay, I'd like to kind of close us out with
Of
the
course.
remaining slides, if that's okay. For those of you who have questions that did not get answered, we'll make sure we address them and do our best to follow up with you at the conclusion of this call. Also, while we were talking about leadership involvement, I thought it was a great opportunity for me to plug in a webinar that we have taking place next week. I just dropped the link in the chat. It's going to be with the leadership from Hackensack Meridian Health, along with their frontline clinical team, talking all things age friendly at their organization. So we'll have both the leadership perspective as well as the folks on the ground doing the work. So if you're interested in joining, it's another free webinar. Go ahead and register with the link in the chat, and you can also forward along to your leadership. So I'm going to go back to the presentation really quickly so we can close out. All right. Can everyone see my screen okay?
Yes.
All right, perfect. So we do have a variety of case examples, which I mentioned earlier in the call, that show organizations that have implemented age-friendly work in their organizations and measured their progress. These case studies feature a wide array of sites. So go ahead and check them out. You can find them either on our webpage, theaha.org/age-friendly, or on IHI's webpage, which has been dropped in the link a few times. We've also got some great podcasts on our website that you can check out. And then again, shameless plug to join the action community. I know we've shared the invitation guide as well as the link to our commitment form. I saw a few registrations come through on this call, so thank you so much. And we look forward to welcoming you on our kickoff call series in September. So Jen, I'll turn it back to you.
Yeah. And again, thank you, Adam, for an awesome presentation today. Really bringing it to life with all of your stories and your data, and your practical advice. Much appreciated. So again, just a reminder that this is being recorded. We will ping everyone once it's available and share some additional follow-up resources. But again, thank you, Adam. Thank you, Autumn, for being here today. And I hope everyone has a great rest of their day and a great rest of your week. Take care.